Okay, so this is going to be chapter 9. I'm going to be working on, for the next several hours, we're going to be working on digestive system and nutrition. So let's go ahead and kind of start off by getting our intro in here on digestive system. So when you take a look at the digestive system, basically all the organs of the digestive system are housed in what we call the gastrointestinal tract, or GI tract. It's basically one long tube with an in-hole, your mouth, and an out-hole, your anus. And then it's broken up into several organs in between. Now, the function of the digestive system is to hydrolyze, and that's just a big fancy word for break down the macromolecules in your food. And then basically, the food will be broken down into its subunits, just like we mentioned before in the previous chapters: monosaccharides, amino acids, fatty acids, all those building blocks associated with our macromolecules. And those are our nutrients. And then we absorb those into our bloodstream. So here's basically what our GI tract looks like. So you start off, first of all, by looking at your oral cavity, so your mouth. And then, of course, the food will go down your esophagus. That's the beginning of the tube, into your stomach, which you have right here. And then from your stomach, it'll move into your small intestines, which is right in the middle. We're going to be taking a look at each of these in turn. And then from your small intestines, it'll move into your large intestines, and then into your rectum for elimination, and then out your anus. So let's go ahead and take a look at some of the processes of the digestive system. The first thing that the digestive system does is ingestion. So ingestion basically is just the intake of food in the mouth. And then once you actually have food in the mouth, then it's time to start digesting. And typically there's two different types of digestion. There's what's called mechanical digestion. This is actually the mechanical shredding and tearing of the food. So basically the chewing process is a type of mechanical digestion. And there's what's called chemical digestion. This is basically where you use your digestive enzymes to hydrolyze the macromolecules into subunits, where you start to break down your food into individual pieces. Then you're going to have the movement of your digestive system. This is basically going to be going from one organ to another, ultimately usually using contractions of smooth muscles that basically line your digestive tract in a process called peristalsis. So this is basically a smooth, kind of a rhythmic, one-directional muscle contraction. Kind of not unlike kind of squeezing a tube of toothpaste. And so that's kind of a lot what peristalsis is like. And then, of course, we go to absorption. So we have to basically move the nutrients across the wall of the GI tract into the bloodstream, and then they'll be delivered to the cells. And then, of course, we have elimination, which is the removal of any of the undigestible stuff. In the process of defecation, that's basically getting rid of your feces. Now let's go ahead and take a look at the structure of this long tube, or the GI tract. First of all, we start off with a term that is a fairly simple term, but you see it in a lot of applications. That's called the lumen. The lumen of the GI tract is essentially the open area, the hollow portion of the organ. And this is where the food or the feces, depending on where you are in the GI tract, is housed. Now, there's typical layers associated with the wall of the GI tract. The first of the layers, the inner. So we're going to start off with the innermost layer and kind of move to the outermost layer. The innermost layer is what's called the mucosa. And so this basically is responsible for doing a lot of different things. I oftentimes will refer to this as the physiological layer. So this is the one that's actually doing a lot of the physiological work we associated with the GI tract. For instance, it'll produce mucus for protection, especially like, for instance, in the stomach. It also produces digestive enzymes. It is also the site of absorption. So it does a lot of the physiological work of digestion. Then underneath the mucosa is what's called the submucosa. Now, this is a region of loose connective tissue, and it's vascular. So this basically houses the blood vessels that will then absorb those nutrients. It has the lymphatic vessels in there that absorb your lipids, and of course it has nerves that will kind of help coordinate all these activities, especially peristalsis, that muscle contraction. Then below the submucosa is the muscularis. And typically, this is associated with the smooth muscle layer that we just talked about earlier in peristalsis. And so there's a couple of different layers. Generally, the inner layer is what is a type of circular muscle. The outer layer is what's called longitudinal muscle. So circular muscle is kind of more like in diameter. Longitudinal means it's going along the length of the tube itself. And this basically is responsible for all the muscle contraction associated with peristalsis, moving the food from point A to point B. And then we have the serosa, which is an outer layer. This is basically called part of the peritoneum. Remember, this is the serous membrane. And it's a tough connective tissue layer. And so those are the layers of the GI tract. So here's basically kind of what it looks like. So you have the lumen, the inside portion. Then you have the mucosa, where you see typically an epithelial layer on the outside. And then underneath that is going to be your submucosal layer, which is this little pink portion. So you can see the mucosal layer is wrapped around the submucosal layer. And then you're going to have your muscularis layer, which you have your two different types of muscles, allowing you to kind of squeeze on the tube. And then this very outer membrane here is going to be your serosa. And so that's the part that we see. And you can see how the serosa basically kind of merges and dovetails into these, what's called the mesenteries. This is the serous liner, the peritoneal lining that basically will connect one organ to another. It's kind of like a sheet of membrane that will connect your intestines together so they're not just all loose. And then they'll also provide passageways for blood vessels and nerves and lymph vessels as well. Okay, so now let's go ahead and continue. So a couple of things that we run into in terms of conditions of the wall is, so we have diverticulosis and diverticulitis. And so in diverticulosis, this is basically is a situation where the mucosal layer will basically push through the outer layers and it forms kind of a pouch. So it pushes outward. And forms a little pouch, and this is basically where food collects. So you can imagine the tube coming like this. Diverticulosis is essentially when that mucosal layer kind of pushes outward like that, and it creates a little pocket. And what can happen is food can collect in there and get stuck in there. Diverticulitis, and with diverticulitis is basically when the pouch becomes infected. And this happens in probably about 10% of the people versus, or a quarter of the people that you see in general, in the general population. With diverticulosis, we'll have some sort of an inflammation or infection of those little pockets. Another one we run into is called inflammatory bowel disease, IBD. So this is basically where you have chronic diarrhea, abdominal pain, fever, things like that. Irritable bowel syndrome is sort of similar. In this case, you get contractions of the muscularis, which can be very painful. It's kind of like cramping. And this can cause a lot of irregularity in your ability to be able to move stuff from point A to point B, right? Constipation, diarrhea, things like that. And so it's just basically an inability to properly pass things through your digestive system. Okay, so let's go ahead and then start, now that we kind of an overall in terms of the basic structure, now let's go ahead and start kind of working our way through the tube from the beginning point to the end point. So we start with the oral cavity of the mouth, right? So basically, there's nothing mysterious here. I mean, we all have a mouth. We all are pretty familiar with it. So essentially, this is where the food begins. And in the mouth, you will be doing mechanical digestion, right? So basically chewing. And you'll also be doing chemical digestion. And so the reason why we have chemical digestion is because of the saliva, which actually is a combination of mucus and liquid and enzymes as well. And so you'll get to work already on the food, chopping it up into smaller and smaller pieces, that's mechanical, and then already started to digest with the enzymes. So in the mouth then, when you have your digestive system versus your respiratory system, the palate, or the upper roof of your mouth is basically separating your nasal cavity, part of the respiratory system, from your oral cavity, which is your mouth, and that's part of your digestive system. So in the roof of your mouth, you have two different pieces of bone, one provided by the maxilla, which creates the hard palate, and then the backside of that hard palate is a palatine bone, which is also, both of those are skull bones. And then at some point, bone, your skull bone, will end, and then you'll feel a soft little dip in your palate. So if you run your tongue on this roof of your mouth, you'll feel like a little soft part. That's your soft palate. And typically the soft palate is muscle, and it ends in your little uvula, which is basically that little punching bag in the back of your throat. Now, we talked a little bit about tonsils already, so I don't want to spend a whole lot of time on them, but basically this is lymphoid tissue that's in the back of your throat. Typically, you'll have a pharyngeal tonsil, so pharynx means throat. So you have a pharyngeal tonsil in the back of your throat, and so you'll have a nasopharynx. That's basically where your nasal and your throat come together. And so these guys are kind of oftentimes referred to as adenoids, these ones that are kind of back there in that nasopharynx area. So this is kind of what it looks like. So basically you have your hard palate here in this upper region, and then you'll hit that little soft spot. That's your soft palate. You have your uvula and your tonsils, which are typically on the side. When they're swollen, you can actually see them and they become quite large. So now let's take a look at the salivary glands. So these are the ones that are responsible for chemical digestion. So the salivary glands are going to be secreting saliva, which is a mixture of salivary amylase, which is an enzyme that breaks down carbohydrates, and lysozymes, which basically is an antibacterial enzyme. We talked a little bit about that last time in the last chapter. Your tongue, which is also part of the situation, is a muscle covered with taste buds, and those are receptors, so we can basically be able to taste food. But this is basically responsible for moving food around in your mouth so that you can position it under your teeth so you can chew it up and get it smaller. And generally speaking, after you're chewing, it'll form what's called a bolus, right? So this is basically the mass of food that's been chewed up, and then it moves toward the back of your throat or the back of your pharynx. Now, for your teeth, this is part of your mechanical digestion. So you typically will have a series of teeth throughout your life. So your deciduous teeth or your baby teeth. Why that's coming up. These are the baby teeth. You have 20 of those. Those will come out to ultimately yield your 32 adult teeth, which are permanent, and they're basically going to be with you for the rest of your life. And you have a couple of main divisions of the tooth itself, right? The crown, which is basically the part of the tooth that you see, and the root, which is the part below the actual mouth itself. So when you take a look at it, on the crown portion of it, you're going to see the enamel, which is the hard outer layer. That's basically what you chew on. Underneath that is a kind of a bony material. It's softer, called the dentin. And then in the middle is going to be the pulp, right? This is where the blood vessels and the nerves are going to be supplying the tooth. And then you have membranes that anchor the tooth to the actual jawbone, the mandible, and the maxilla. So it's kind of what it looks like. So here is your enamel up here on top. That's kind of like the part that you chew on. Underneath that is the softer dentin that is not as hard and structural. And then below that is your pulp. So your pulp has a lot of vascular blood and a lot of nerves and things like that in it. So this is what we refer to as the root. That goes all the way down into the root system, and you can see how it connects to the underlying blood vessels and the nerves that basically feeds into the tooth. And then the root of the tooth is connected by all these little connections. These are what's called periodontal ligaments. And so that's actually what's holding your tooth into either your mandible or your maxilla. And so that's what's holding it in there. But generally speaking, when you take a look at teeth, tooth decay or dental carie is essentially a cavity. And this occurs because when you have sugar in your mouth, the bacteria will metabolize the sugar, and that produces acids. And the acids will basically erode away the teeth. And so this can be certainly painful, especially if it hits the nerves. The reason why tooth decay hurts is because it gets down to the pulp and starts to affect the nerves. Gingivitis is basically inflammation of the gums. Oftentimes will cause wear and tear on the tooth and also loosening of the teeth. So you can lose the teeth through gingivitis, and periodontitis basically is the loss of the actual bone itself, and that'll actually loosen the teeth. So those are all different types of situations you can run into in the mouth and the teeth especially. So the mouth and the nasal passages basically will lead down into the pharynx, right? So we already talked about the nasal pharynx. That's the portion of the throat that is connected to the nasal cavity. And then what's going to happen is the pharynx will basically open up into another passage, the esophagus, which starts to head down into your chest, along with your trachea, which is taking in air. And so these tubes are parallel to each other. So the trachea is in front of the esophagus is behind it. The esophagus is a muscular tube that's behind your trachea, so you don't ever actually feel it, but you can feel your trachea. If you feel the front of your throat, you can feel those little ridges. That's your trachea, so you can actually feel your trachea. So the first step is to swallow. All right, so now that you've got this food bolus, you got it chewed up with your teeth. That's mechanical digestion, and now you've also got it mixed with your saliva for enzymatic breakdown. That's going to be your chemical digestion. Now it's time to swallow it. So what happens is you use your tongue to move your food bolus to the back of your throat. Now, this part is voluntary, right? So that's where it starts off to be voluntary. You can choose whether or not to move the food back to the back of your throat or not. But once it gets back to your throat, then it crosses the threshold, typically right at the gag line. And then it becomes involuntary. As the food enters into the esophagus, it'll start to move down into and heading toward your stomach. But what about the trachea? Because we said the trachea was there as well. So how come food doesn't just go down to the trachea when we swallow? Well, the reason is because these avenues are blocked. As a matter of fact, as the food moves back to our soft palate, we have a little piece of cartilage that sits on top of the trachea. And this is called the epiglottis. And the glottis is basically opening to the trachea, where you'll find your voice box, which is called the larynx. Now what happens is the food will actually shut the epiglottis, closing off the trachea. And so this is kind of what it looks like. So here you can see your nasopharynx, which is basically the region right behind your nasal cavity. And what happens is as you move the food back across your soft palate, which is this little piece right here, the food is going to head down the back of your throat. But here's this little piece of epiglottis right there. And so what's going to happen is the food is going to land on that epiglottis. That bends it over and shuts off the trachea, only allowing your esophagus as the only way to go down. And that's the reason why you don't choke on your food when you swallow. As it goes down the esophagus, basically it goes to peristalsis. So remember I said peristalsis is a rhythmic wave of muscle contraction. So your food bolus now in your esophagus is starting to move. In order to move it down your esophagus, what happens is your esophagus contracts by peristalsis, by contracting at a point behind the bolus. That basically is effectively going to squeeze the bolus forward in your tube, just like you're squeezing a tube of toothpaste. And then what happens is it squeezes the next segment to continue squeezing it forward, and then the next segment to continue squeezing it forward until it gets to the stomach. So it's not unlike you squeezing a tube of toothpaste, right? And that's what we mean by peristalsis. It's this rhythmic, uniform, unidirectional wave of contraction. The other thing we learn in terms of musculature is what's called a sphincter. A sphincter is a ring of muscle that acts as a valve. So literally what happens is you have an opening that is a tube and you have a ring of muscle around it. That's a sphincter. When the muscles contract, it basically closes off that diameter or shuts it down. When it relaxes, it opens it back up. So basically this is kind of, it's like a cinch cord, right? So when it contracts, it like cinches down on the tube, shutting off whatever's coming through. And when it relaxes, it opens up the tube, allowing passage. And so ultimately, what we see first as we go from the esophagus then to the stomach is we see a sphincter. In this case, the lower esophageal sphincter. This is the will close off the esophagus from the stomach. Now, generally speaking, when you get a failure of the sphincter, you get heartburn. You essentially get stomach contents moving into the esophagus, where the stomach acid will burn the esophagus, and it hurts. So, for instance, vomiting essentially is not peristaltic, but basically this is where you have strong spasmodic contractions of the stomach and the abdominal muscles and the diaphragm as well. And this forces basically content. And so that's lovely. But that's basically what vomiting is. It's like a muscle spasm of the stomach and your abdomen to basically eject material out of your body. Okay, so now that's the esophagus. Now let's go ahead and move into our next stopping point, which is going to be the stomach. So the stomach has a couple of jobs. One of the jobs is to store food that you eat. It also, however, is going to begin the process of digestion, especially proteins. And then its job is to move that food into the small intestines. Now, one of the things it doesn't do is it doesn't absorb nutrients. There's no absorption going on here. So like the food that you eat doesn't get absorbed in your stomach. However, it can absorb alcohol. That's because it's fat soluble. And it's a different way of absorbing. You absorb alcohol differently than you absorb food. And so when you take a look at the stomach, unlike the rest of the GI tract, which simply has in its muscularis layer 2 layers of muscle, right? It has circular and longitudinal. The stomach has 3 instead of 2. So it has circular and longitudinal, right? We know about those, but then it also has a 3rd layer, the oblique layer. So it has an extra layer of musculature, which makes the stomach a very muscular organ. And so this is kind of what it looks like. So here you can see you have your lower esophageal sphincter, which is going to basically close off the esophagus from the stomach. And then we kind of cut this open and you can see a couple of things. So first of all, you can see the muscularis layers, right? You can see your 3 layers of muscle, your circular, longitudinal, oblique. You can, on the inside surface, you can see the mucosa layer is organized into ridges called rugae. And so you can actually see the scanning electron micrograph. That's a real stomach we're looking at right there. What it actually looks like on the inner surface of the stomach. So you can see all those like little wrinkled areas and those rugae. You can also see what looks like little holes. Those are gastric pits. On the other side of the stomach is another sphincter, right? This sphincter is called the pyloric sphincter, and it closes the stomach off from the small intestines. We'll talk about that once we get there. Now, the functional unit of the stomach is what's called the gastric pit. So the gastric pit basically is an invagination of the mucosal layer of the stomach. And so what will happen is you kind of dip down in this sort of epithelial layer of your mucosal layer will kind of dip down and create this long shaft-like pit. Those are the holes you're seeing up here in this electron micrograph. And those cells are secreting different things into, like acid and enzymes, into this pit, creating kind of like this sort of bubbling brew of acid and gastric juice coming out of these little pits. So if you've ever seen a volcanic mud pit where you kind of see gases bubbling out of the mud pit, that's kind of probably what it looks like on the inside of the stomach, as these gastric pits are secreting this and sort of getting this out into the stomach itself. So basically, when you take a look at how things are happening in the stomach, the food comes in through the lower esophageal sphincter into the stomach, and the stomach begins to contract. So one of the things the stomach does is it also does mechanical digestion, in the sense that muscularly it basically squishes on this food bolus. And it's by doing this, it's going to be contracting its walls, and it's going to be sloshing the food from one end back to the other, back to the other, and back to the other. So it's this back and forth kind of washing machine like agitation cycle where you see food bolus being shifted back and forth and back and forth. This type of muscle contraction is what's called segmentation. I call it the sloshing contraction. It's like you're trying to mix this up. Why? Because in this particular area, what's happening is your job is to take the food bolus, which is kind of a paste, right? Kind of a semi-solid paste. It's basically the same consistency as what you swallow. And it's designed to turn it into now what we refer to as chyme, which is liquid. So you're liquefying this pasty food bolus. That's what your stomach is doing. So heartburn, which is GERD, basically is a situation where you have the stomach acid that begins to enter into the esophagus. And since the esophagus is not protected from acid, it hurts. And so in pregnancy, a lot of times women will get heartburn because the baby is pushing up on the stomach and kind of causing that to go up into the esophagus. Gastroesophageal reflux disease, GERD, is basically chronic heartburn. That's pretty much what it is. So the mucosal folds, the rugae, like I said before, will basically form gastric pits. And in these gastric pits, these cells that are secreting gastric juices are organized into what's called gastric glands. So these are basically structures, cellular structures, in the pits, whose job it is to produce this gastric juice. And of course, in this gastric juice, you have a couple of important things. One is an enzyme, pepsin, which basically is a protein cutter. So already your stomach goes to work on proteins. The other one is hydrochloric acid at about a pH of 2. And so a couple of things that happens here. Number one, if you swallow any bacteria, chances are pH of 2 is going to kill them. Also, it activates pepsin as well. And then, of course, it produces mucus, basically to protect itself from acid burn. So generally speaking, when you eat food, it'll take a few hours for your stomach to empty, between 2 and 6, depending. But what leaves the stomach is chyme, right? So this is basically a mixture of food and gastric juice, and it is typically a liquid at this point. So this will be injected through the pyloric sphincter, and then it'll move into the small intestines for further digestion. Now let's take a look at the small intestines. Next stop, small intestines. So the small intestines is basically named for its diameter compared to the large intestine. So that's what we saw when we basically did dissections, right? And so the small intestines has a couple of major pieces. It's a very long piece of the organ, right? About 6 meters or about 18 feet. Still very, very long, essentially, when you take a look at it. Now, it has 3 different regions. It has what's called the duodenum, the jejunum, and the ileum. And so each of these has different things happening in them that are really important. Now, a couple of things also to mention as we get into the small intestines is there are some helper organs, or what's called some accessory organs, that are associated with the small intestines, especially the events of the beginning of the small intestines called the duodenum. So the duodenum is the first portion of the small intestines. And in the duodenum, this is the one that's receiving the chyme first. Remember, a couple of things have to happen in the duodenum. So basically, chyme is acidic. Why? Because it's been mixed with those gastric juices. So it needs to be neutralized. And that's one of the jobs that happens in the duodenum. The pancreas, at this particular point, is an accessory organ, as is the liver. And these guys are secreting their secretions into the duodenum region. So for instance, the pancreas will make a lot of pancreatic digestive enzymes and will secrete those enzymes into the duodenum, which is that first portion. Another one is bile, which is that green, bitter, we oftentimes in history call it gall. So something is galling, it's bitter, it's very, very foul tasting, is going to be made by the liver It's stored in the gallbladder, and it's going to inject that bile into the duodenum. Now, here's what bile does. First of all, bile's big job is to emulsify fat. Basically, what that means is you essentially break fat down into smaller, more manageable droplets. That's what an emulsifier does. So it causes these fat droplets to disperse in the water, and then it exposes it to a fat enzyme, a fat digesting enzyme called lipase. Now, the lipase itself is going to be produced by the pancreas, pancreatic lipase, and it hydrolyzes the fat and it'll break it into glycerol and fatty acids. If you recall from our previous chapters, those are the two components of your fat molecule. The other thing is also is the pancreatic secretion and bile, we put that in there, is alkaline. So it will also neutralize the chyme, keep it from burning your duodenum. So your pancreatic juice, so what happens in the duodenum is your pancreatic juice has alkaline buffers in it and digestive enzymes in it, goes through the pancreatic duct, mixes with the bile, which also has alkaline salts in it, and then is injected into the duodenum, neutralizing the chyme and emulsifying the fats. And of course, those duodenal enzymes, or those pancreatic enzymes, start acting on the food that you ate, starts breaking up all of those molecules. So the main digestive organ is the small intestine, right? So for instance, this is where we're going to see a lot of what's called pancreatic amylase. This is basically an enzyme whose job it is to digest carbohydrates. And that's secreted into, that will basically chop up all the sugars that you eat. Trypsin, which is also produced by the pancreas. This one is what's called, it digests proteins. So it's called a protease. So pretty much any enzyme that is a protease is a protein cutter. And so it'll digest up those proteins that you've eaten. And so in that pancreatic juice, you have sodium bicarbonate, which is basically like baking soda. This is what causes it to be alkaline. So sodium bicarbonate is the same thing as baking soda. And that will neutralize your chyme. So here's basically a table of your enzymes. I'm not going to really go over these, but you can see you've got salivary amylase from your mouth, which will then give way to pancreatic amylase from your pancreas, and you have maltase by your small intestine. Your protein cutters, you have pepsin, trypsin, and peptidases of different types. And then you have proteins that cut up nucleic acids, DNA and RNA, so nucleases and nucleosidases. And then you have fat cutters, right? Salivary lipase and pancreatic lipase. Okay, so now once you cut up all your macromolecules into their building blocks, it's time to absorb. The small intestines will also be responsible for absorbing this, but they do it in a slightly different portion of the small intestines. So along the liner of the small intestines, the mucosa organizes itself in a structure, an absorptive structure called the villi. The villi is the absorptive structure. Of your intestines. And each villus is covered with small little extensions called microvilli to increase your surface area and your ability to absorb nutrients. So what this does is it gives it kind of like a little fuzzy liner, like little peach fuzz. And we oftentimes will refer to this as the brush border. Now in the brush border, like lions lurking in the grass, are what's called brush border enzymes, who will basically do the very final cuts of digestion before absorbing it into the bloodstream. So here's kind of what it looks like. So here basically you can see they've got a blow up of a villus. So you can see how your submucosa basically pushes up into the mucosa layer, lifting like a finger-like projection this villus and extending it out, lined with these columnar absorptive cells. Now, on the surface of these columnar absorptive cells, and you don't necessarily see them, oftentimes you'll see what looks like a little, I'm going to do it in purple, what looks like a little kind of like, almost like eyeliner on the surface of these columnar cells. That eyeliner little surface is the microvilli. So if you kind of blow that up, you can see here are the microvilli fibers, and this is the villus here. So that increases your ability to absorb nutrients. So generally speaking, all the nutrients are absorbed in the small intestines, typically through the villi. And this kind of has the capillaries and also the lacteals, which are the lymphatic capillaries. And remember, the lymphatic capillaries are designed to absorb fat. So if you take a look at this kind of bears, the important thing is what happens is here you have your liner, your little nutrient out here. And what's going to happen is it's going to go through the cell layer and it's going to be absorbed into the capillary and into your bloodstream. Or if it's a fat, it's going to go through the cell layer and into the lacteals, that lymph vessel that basically will absorb the fats. Now, pretty much sugars and proteins, so monosaccharides and amino acids, they go directly into the capillaries of the villus. However, lipids are a little bit different, right? So glycerol, fatty acids, things like that, or lipoprotein droplets typically will form, and they're called chylomicrons. So basically, a chylomicron is what enters into the lacteal itself. So a chylomicron is basically a protein that carries your lipids. So rather than just like your lipids just going straight into your lacteals, the chylomicrons will actually gather them up, grab them, and they'll transport them into the lacteals. And so then they'll kind of go into the blood. So here's kind of what it looks like. So you can see you have your carbohydrates, which will go through your cell layers directly into the blood capillaries. You have your amino acids, which will go directly into your capillaries. Your lipids, which have been emulsified by the bile salts and broken up into smaller and smaller pieces, will then basically go in. They'll get captured or grabbed onto by this protein, this chylomicron shuttle. And the chylomicron is the one that will shuttle it into the lacteals, and that's where your lipids will go. So your lacteals, or those lymph capillaries, are the ones that are responsible for absorbing the lipids that you eat. So let's take a look at some disorders. So lactose intolerance, for instance, is basically where you do not have the brush border enzyme lactase. So lactase is supposed to make a final cut to separate glucose from fructose before you absorb it. But if you don't have that, then the lactose doesn't get in, and then it just passes through, which is the reason why it creates a little bit of diarrhea and gas and bloating, is because you got a lot of this lactose that's basically staying inside your GI tract because you're unable to absorb it due to this deficiency in this brush border enzyme. And so that's basically what happens. So pretty much if you can't absorb it, then it just passes through. Right now, that either just passes through passively, or it can pass through with a great deal of symptomology, like, for instance, cramping, gas, diarrhea, things like that. So celiac disease is typically another one that we see. So this is an autoimmune disease, right? So that means your immune system is basically attacking normal tissue, or something normal, not necessarily normal tissue, but something that's kind of normal-ish, like gluten, for instance, is a normal component of wheat and many grains. But for a person with the celiac disease, they basically will mount an attack on gluten as if it's a pathogen. And then that'll cause a lot of problems. For instance, the the presence of that gluten inside the digestive system will create an inflammation because your body thinks it's foreign. It's basically trying to reject it. And this could damage the villi, the microvilli, this inflammation piece, not the gluten itself, but it's your body's response to the gluten that causes the problem. And this could cause a lot of different types of gastrointestinal problems, for instance, abdominal pain, diarrhea, malnutrition, gas, things of that nature. Okay. So now let's take a closer look at the accessory organs, starting first of all with the pancreas, right? So the pancreas basically is a fish-looking, it looks like a Gorton's fish patty, but basically this is right behind the stomach, and its job is to produce pancreatic juice. And what happens is it will basically offload that pancreatic juice into the pancreatic duct, which will then connect to the duodenum and then deliver its mixture of sodium bicarbonate and digestive enzymes into the small intestines. And so that's kind of what it looks like. So here you can see your Gorton's fish fillet there. And so this is the body of the pancreas. This middle portion here, this is the pancreatic duct. So this whole region right in here is the pancreatic duct. So what happens is the glands, which is the exocrine activity, is going to be producing these enzymes, dumping it into the ducted system, and it's going to go through the pancreatic duct on its way to the duodenum. Now, at the same time, the liver, which is up here making bile, the hepatocytes all make bile, is basically going to dump that bile freshly from the liver into a series of ducts that will then merge into what's called the common hepatic duct. And then this will keep on going. But you also have the gallbladder. The gallbladder basically stores bile. And so you have bile in the gallbladder as well. And so the gallbladder will contract and deliver its bile through what's called the cystic duct. Now, when the common hepatic duct and the cystic duct merge, they become basically the bile duct. And your bile will move through the bile duct. And what it does is it basically merges with the pancreatic duct, and it mixes right in this little area right before it goes into and it gets squirted into the duodenum. And so that's kind of what's happening here. So this right here is a cross section of the basic unit of the liver. And it's called a liver lobule. So generally speaking, whenever you absorb blood, whenever you absorb nutrients in your blood, it gets collected and then it gets moved to your liver so that your liver can metabolize it and then before it sends it out to the rest of the body. So that's what this piece is right here. So these guys right here is what's called the portal triad, these three. So you're going to have, first of all, a branch of what's called the hepatic portal vein. Basically, this is blood with absorbed nutrients that you've just eaten. It's coming to the liver to get checked down so that the liver cells can metabolize them, make sure everything's safe, right? So what happens is the blood comes through this hepatic portal vein and it goes through these little sinusoid channels. And what happens is they basically kind of diffuse out into these hepatocytes. Those are the liver cells. And so you can see multiple channels here. So it's kind of like irrigation canals in a farm. Basically, they're kind of moving out and sort of bathing these cells in venous blood. And those cells are metabolizing it and they're dumping it back into the bloodstream. And it basically moves toward what's called the central vein, which will then move up to the heart. It looks like PowerPoint's about ready to crash on me, so just bear with me here. Now, the other part of the triad is the hepatic artery. So then we have the hepatic artery. And this is basically blood coming from the heart that basically feeds the liver cells. And so that's necessary. And then the last member of the triad is this guy right here. This is the bile duct. So the hepatocytes are the ones that make bile. They make the bile, and then they're basically going to dump that bile into the bile duct, and it's going to go and be delivered. So this little bile duct, I'm going to follow my arrow here, is going to go all the way over here. And then it's going to go into this little bile duct for delivery, either to the duodenum or to the gallbladder, depending on whether you need it or not. Okay. Okay. So the pancreas both has exocrine, that means it's secreting enzymes and digestive juices, but it's also endocrine as well, because it also secretes hormones that go directly into the bloodstream, insulin, for instance, and also glucagon. So these basically are regulating your blood glucose levels. So in type 1 diabetes, typically you don't have enough insulin, or your insulin is not doing its job. And so this is typically something that gets diagnosed early on in childhood, and you're usually working with this for your entire life. Type 2 diabetes is essentially where the body cells are essentially either not listening anymore to insulin, or there's something wrong with insulin for some reason. And so this will occur typically in adulthood, and it is usually correlated with either obesity, inactivity, or if you have a family history of diabetes. So the liver, which is the largest gland in the body, is kind of going to be in the upper right quadrant. So it's going to be right in the upper portion of your abdominal cavity, just below the diaphragm. It's organized in the lobules, which we just saw. And its job is to essentially filter the blood, those new nutrients that you just absorbed, metabolize them, remove any poisonous things before you release it out to the rest of the body. So this is just basically a list of some of the functions. The liver does a lot, right? So that's the whole story of the liver function. The liver function basically does a lot. It does pretty much all your metabolism. It'll destroy old red blood cells and basically break that down. It detoxifies your blood by taking poisonous things out of your blood. It stores iron, and oftentimes is a main site for the metabolizing of vitamins that you eat. It makes the plasma proteins that are in your blood plasma. It will store glucose and glycogen. Typically, it'll also break down amino acids. It regulates your blood cholesterol. So it pretty much does just about everything. So all of the metabolic reactions in your body that are going on, a good chunk of them are happening in your liver. So your liver does a lot. So it'll store vitamins, for instance. It'll also store your glucose in the form of glycogen so that you can have a little bit of carbohydrate reserve for energy purposes. So if you need glucose in order to burn energy, then it'll break down that glycogen. You can think of it as sort of like a pantry, right? It's kind of like a little backup system. And so what'll happen, it can also take glycerol, right? Typically from your fat molecules and amino acids. It can convert those into glucose. So there's a lot of things going on there. And then when amino acids are turned into glucose, oftentimes urea is formed, which is actually an important molecule when it comes to producing urine in the kidneys. So the plasma proteins that are in your blood oftentimes are lipid shuttles, things like albumin and stuff like that. Those are coming from the liver, and your cholesterol levels are also coming from the liver as well. So the liver does a lot in addition to what it's doing with your digestive system, which is producing bile. And these bile salts basically will be alkaline in nature. And of course, it'll also have a bicarbonate, right, which is also alkaline background. And so it'll be full of bile salts, water, cholesterol will be in there, and of course bicarbonate. So it's kind of a witch's brew of a lot of different things. One of the things that it does contain, however, is bilirubin. And the bilirubin is basically part of the pigment breakdown associated with your hemoglobin. So your hemoglobin, which is your red pigment in your blood that carries oxygen, is broken down and recycled. And part of its breakdown product is bilirubin. And so you put that breakdown product to use in your liver. The gallbladder basically is a storage unit So basically, it's a little kind of a bulb-shaped structure that's tucked inside the two lobes, smashed in between the two lobes of the liver. And so if you have excess bile that you're not going to need for digestion, then you just store that excess bile in your gallbladder. And so typically when you suffer from things like gallstones, this is basically where you get a coagulation of the bile or a hardening of the bile, and it creates a stone-like bile hardness or a hardening of the bile if it gets too concentrated. So what about some disorders? Let's take a look at a couple of disorders. Well, first of all, a couple of major ones are things like hepatitis. So hepatitis basically is inflammation of the liver. So anything that's an itis is essentially an inflammation. And hepa refers to liver. So hepatocytes, hepatology, that's basically liver. And so this will be inflammation of the liver. Hepatitis has different types of forms. The other one is cirrhosis. Osis means the condition of. And in cirrhosis, basically, you have scarring of the liver tissue, which causes it to not be able to work functionally. So it's not able to deliver bile functionally. And so what happens is your bile pigments will start to leak into the bloodstream, and that causes jaundice, which is basically this yellow tint in the eyes and the skin. That usually means that there's some sort of liver disorder going on there. Your liver's not properly processing and moving bile through the system. And so jaundice is typically a sign, a bad sign, that there's something going on with your liver. Now, hepatitis has a couple of different forms, and some of you guys may have already gotten vaccinations for some of these hepatitis types. They're out there. So there's A, B, and C. So basically, A is the one that we worry about when we're looking at drinking water and food. So contaminated sewage, contaminated drinking water or food. So if you're drinking contaminated water, then hepatitis A is a common thing that you see, and it causes liver inflammation, and that's a bad thing. Hepatitis B typically is the sexually transmitted one, or transmitted through blood infusions or blood transfusions. And so this one is worse, actually. It's more contagious than AIDS, but it spreads the same way. But we do have vaccines for hepatitis A and B. Now, C is typically acquired, you have to get it from infected blood. So this can lead to chronic hepatitis, liver cancer, and death. So if you're in a healthcare environment, oftentimes you're really concerned about hepatitis C, especially if you're dealing with patients and blood samples and things of that nature. Cirrhosis is a situation where the liver becomes fatty. Now remember, fat is a type of connective tissue, right? And then that will convert into scar tissue, fiber scar tissue, which is a more dense type of connective tissue. But the idea being is that the connective tissue essentially creates a loss of function because it gets in the way, right? So the connective tissue basically gets in the way, and it can't do what the liver's job needs to do. So oftentimes you'll see this in people who abuse alcohol, or who are malnourished. If they're excessive drinkers or extremely malnourished, you can get cirrhosis of the liver. We're also starting to see cirrhotic medication-induced non-alcohol versions of cirrhosis. That is for people who are on chronic medications for a long period of time, oftentimes will develop cirrhosis of the liver. And that's not because of alcohol, but because of their chronic maintenance, like maintenance drugs that basically they have to take routinely throughout life. The sooner you start those maintenance drugs, the more likely you're going to have a cirrhotic liver later in life. And so that's the reason why you want to try to get your body healthy as possible, and you want to try not to have as much medication as possible. Let your body do it naturally. Okay, let's take a look at some regulation, right? So how do we basically regulate all these digestive secretions? Because, I mean, there's a lot of them out there, right? So your digestive juices, for instance, gastric juice, digestive hormones basically are going to be behind a lot of this. It's also controlled by the nervous system. So you're going to have a combination of both nervous system control, the digestive system, and also hormonal control of the digestive system. So one thing to understand is that basically when you start this whole process off, it begins with your sense of smell. So your sense of smell is basically going to trigger a division of your nervous system called the parasympathetic nervous system. So typically this is the one that we associated with our visceral core organ systems, right? The ones that are kind of on autopilot that we don't think about. And what this does is it basically stimulates gastric secretion. right? That's when you smell food. It's something that we refer to as the cephalic phase of the gastric cycle in anatomy physiology. So if you have a protein-rich meal, the stomach will start to produce gastrin. And so this will then, this is basically the main hormone, will facilitate gastric activity. So what it'll do is it'll start to activate those gastric glands. Remember, those gastric glands are making pepsin and acid. And so this is kind of what it looks like. So ultimately, then you're going to have your bloodstream, which is going to be communicating back and forth. So from your stomach, you're going to see you have gastrin, which is basically going to your bloodstream, and it's going from your bloodstream to your stomach to control gastric activity, what your stomach is doing. Then you have two others, one which is called secretin, which is working at the point of your duodenum. So you can see here that the secretin is going to be coming from your duodenum. The signal is going to be coming from your duodenum, but then it's going to be signaling back to your gallbladder. Typically, secretin is regulating your gallbladder activity and your duodenal activity in response to undigested protein in your duodenum. The CCK, which is cholecystokinin, we'll talk more about these here in just a second, is doing the same thing. It's also triggered by protein, and it comes out of the bloodstream, but then it also communicates with the gallbladder. But cholecystokinin also communicates with the pancreas as well as secretin, which is also communicating with the pancreas as well. So you can see how these hormones basically are triggered, first of all, by the presence of undigested food in your digestive system. And then it starts these regulatory signals that then coordinates and regulates the activity. So for instance, let's take a look at secretin. So secretin is secreted by the duodenum. And typically it's released when the chyme is present. Usually it's looking at protein, undigested protein is going to be what's triggering that. And it's also stimulated by hydrochloric acid. So for instance, when you feel that hydrochloric acid coming into the duodenum, it'll trigger the release of secretin. Cholecystokinin, which is the other one that we looked at, is also released by the duodenum. This is happening when proteins and fats are present from your meal. This will go back and communicate the liver to increase the production of bile. And it also causes the gallbladder to contract, basically releasing or storing that, or releasing that stored bile. And so what this will do is the combination of secretin and cholecystokinin will increase both the production and the delivery of bile and pancreatic juice. So they're basically regulating that delivery piece. Okay, so we go through the small intestines, we absorb it. We take what we can, we leave behind what we can't get. So as we kind of go to the end of the small intestines, what's inside our chyme is becoming progressively less and less and less useful and becoming more and more just basically a pile of discard. And so that's when we move into the large intestines. The large intestine's job is to prepare the feces. So now you're basically have undigestible, unabsorbable material. It's time now to prepare it for elimination. And that's basically what the large intestines are doing. It has a couple of major parts. So it has the cecum, the colon, and the rectum, and then of course the anal canal. It's larger in diameter than small, which is the reason why it's called large. And the cecum is the first part. Now attached to the cecum is your appendix, which is basically a little projection off the cecum. So if you take a look at the cecum, as the small intestine basically enters into the cecum is kind of like this sort of large, swollen pouch-like structure. So it's a little more pouchy-like, like that. And then your appendix is sort of hanging off the end of that cecum. And so generally speaking, your appendix is actually part of that lymphoid tissue. So it's part of that lymphoid process we talked about in the previous chapter. Now, if you have appendicitis, this is basically an inflamed appendix, or peritonitis basically is life-threatening, right? So a peritonitis basically is essentially when you get the rupture of your GI tract. and you're going to spill your chyme into your peritoneal cavity. It's very, very deadly. It can be very deadly. And so appendix will do that if they burst. This is what it looks like. So here's your small intestine, the so-called ileum at the end, the last part of the small intestines. It's going to basically eject the chyme through this little opening right here. And that little opening, I'm not sure why they don't have it labeled here, is the ileocecal valve. It's another sphincter. And so it'll fill up your cecum full of chyme. And of course, here you can see your appendix. And then your colon is broken into a couple of major pieces. First of all, you have your ascending colon, which goes up, your transverse colon, which cuts across your body, your descending colon, which goes down, your sigmoid colon, which looks like a little S shape. And then you have your rectum, and then, of course, your anal canal. So basically, that's where your feces comes out. So you have your ascending, transverse, descending, and then the rectum. I'm not sure why they didn't bold out the descending piece here, but I'll go ahead and underline that one for you. And so after it goes basically through that process, then it enters into the rectum, which kind of stores your feces until you're ready for elimination. And then you have to relax your anal sphincters, another set of sphincters, closing your anus so that you can actually get the elimination of the feces itself. So what does the large intestine do? Well, first of all, it doesn't produce any enzymes, so it's not doing any of that, so there's no digestion there. It doesn't really absorb nutrients, except some vitamins. It will absorb some vitamins, not very many. So it's not doing absorption. The one thing it does, however, do is it does absorb water from the feces. This basically allows you to prevent dehydration. So one of the reasons why that diarrhea comes out watery is because your large intestines aren't absorbing the water correctly. It will also absorb vitamins that are basically being produced by your intestinal flora. Remember, those are your natural bacteria. And so basically these guys will help us out a little bit. They'll kind of break down some indigestible material. They'll produce some of the B complex vitamins, vitamin K, for instance. So these guys will help us and we'll be able to absorb those vitamins. So then once we actually bundle this up, so we're largely what you're looking at is the function is water absorption and vitamin absorption. And so when we take a look at the feces, typically about 3/4 water, 1/4 solid waste. Bacteria and any dietary fiber, that's the indigestible remains. That's the solid portion, just basically passes through. So when the bacteria digests these indigestible materials, it causes a smelly byproduct, right? That's basically creates the odor and also the gas associated with that. Stercobilins and the urobilins, which are coming from the breakdown of bilirubin, or that's from the breakdown of blood, enters into your large intestines. And these guys are yellow. These are yellowish pigments, which is the reason why the feces is brown in color, is because of those blood breakdown products. It's also the reason why your urine is yellow, is because of those blood breakdown products. So basically, when you take a look at then defecation, essentially peristalsis is what forces the feces into the rectum. And then once it's in the rectum, the rectal walls will stretch. That will signal nerve impulses going to the spinal cord, and that will stimulate those rectal muscles to contract. But the anal sphincters, you have two sets of them, inner and outer sphincters, will have to relax. They relax, allowing your anus to expand or to open up. This will allow the feces to basically move through the anus. But we do have some control over it, right? So we can inhibit defecation, obviously by contracting the external sphincter, basically holding it, essentially is what that is. That is skeletal muscle. So the inner sphincter is involuntary. The outer sphincter is voluntary. So we can basically hold with the outer sphincter. Okay, what are some disorders of the colon rectum? Diarrhea, first of all. This is basically where you have peristalsis basically ramping up, and you fail to absorb water from the feces, basically it just passes through with all the water in it. Constipation is basically when you have hard, dry feces, and so you have lack of water in your feces itself, so it's not able to move through. Hemorrhoids are basically blood vessels, inflamed blood vessels of the anus, and this is usually because of chronic constipation. Pregnancy, aging can do this. And so these are just basically exposed, inflamed blood vessels that are exposed to the outside. Of the anus. And then, of course, we talked about diverticulosis. We already talked a little bit about irritable bowel syndrome. So this is basically where you have spastic colon, right? The muscularis contracts powerfully, but without the normal coordinated contraction, and this can create a lot of cramping and constipation and a lot of problems. IBD, we also talked about this one already. A couple of things fall under the IBD, inflammatory bowel disease, so ulcerative colitis, which is essentially an issue of the large intestines and the rectum. This is basically will result in rectal bleeding, where you kind of have ulcers, bleeding ulcers, diarrhea, things like that. Crohn's disease, usually it's a small intestine thing. This is basically where you have ulcers in that intestinal wall. They're typically painful and bleeding. They'll oftentimes erode that connective tissue layer underneath the mucosa, that submucosal layer. And so this is where you have nerves and blood vessels. This is the reason why there's pain associated with this, right? So you can't, if this is happening to your submucosal layer, you're unable to absorb those nutrients very easily, because that's where your capillaries are to absorb those nutrients. If they're having a problem because of these ulcers, you're not going to be able to do that. And so you have the same types of symptoms: diarrhea, cramping, things like that. Polyps and cancer, right? So basically, these are polyps is basically a small growth in the colon lining. They can be benign, just like little growths, kind of like a little bump on your skin, which is no big deal. Or they can be cancerous because they're due to overgrowing cancerous cells. Typically, if colon cancer is detected, sometimes it's confined to a polyp, but sometimes you'll basically screen for these polyps. And so dietary fat intake can increase your colon cancer risk. Fiber typically is a good thing, and so it'll inhibit colon cancer and it'll help to kind of regulate things. Typically, we think colon cancer is because when we eat stuff, it gets lodged or spends more time. And let's say, for instance, it's somewhat carcinogenic. So basically, it causes cancer, some sort of a chemical in our food. But what happens is it gets lodged or spends abnormal amounts of time in our colon, exposing our colon to these carcinogenic chemicals, which over a long period of exposure causes cancer. And where fiber comes into play is fiber has a way of kind of scrubbing out the colon. So any of those potential carcinogenic molecules that are like lingering in the nooks and crannies of your colon get scrubbed out by this dietary fiber. And so basically it eliminates it and reduces your exposure to these molecules. Okay. So now let's talk about nutrition and weight control. So obviously weight control, that's obesity. It's a huge thing with the US. We think almost not quite half of adults and almost a quarter of children are obese. This is basically where you have an excess of body fat associated with a lot of different things, right? So for instance, type 2 diabetes, it increases hypertension, your ability, your cardiovascular disease, stroke, which is all part of cardiovascular intent, osteoarthritis, and types of cancers. So all of these are kind of increased in frequency for individuals who are carrying weight. Now, here's the question: how do we define obesity, right? So, in the healthcare industry, we have what's called the BMI, the body mass index, which is basically a ratio of your weight relative to your height. So generally speaking, if you have a BMI of 30 or greater, then we basically get the ratio of your weight to your height. So this is kind of what it looks like for BMI values. Typically, we like to see BMI values that are, around below 25 or so, between 18 and 25. If you're from 25 to 29, you consider it overweight. If it's over 30, it's obese. If it's over 40, it's morbid obesity, which means gross obesity. And so this is kind of what it looks like. So this is like a body mass index, right? So here's your BMI going in this direction. This is your height in inches. So, so I am about 5'10", and I'll do mine just to show you how this looks. So I'm about 5'10", right? So basically 6 foot is 72. So I'm like around 70 inches. That's my height. Now, for me, my weight in pounds is about, let's say it's about 170, right? So I'm kind of like right here. Whoops. I'm like right here. So depending on when I'm doing it, so it's kind of like right in that sort of green zone. So I'm kind of like right in this area, right on the edge of normal and being overweight. So that's basically just a rule of thumb. Some doctors live and die by that. Some don't. But here's the problem. There's a serious caveat to BMI that you have to be aware of. Here's the thing. BMI assumes, it's a false assumption, that weight is due to fat. There is no allowance in BMI for the weight of muscle or bone. Now, what does that mean? So for bones, it's probably not that big of a deal because for the most part, the average bone for the average person, so like if you were to compare the size and the weight of my femur to another person or another male who's also about 5'10", probably the weight of our bones would be about the same. However, muscle is quite heavy. Matter of fact, muscle is heavier than bone, or heavier than fat. So if you're muscular and you've been building your muscles, then you're going to have a higher BMI, but not because you're fat, but because you got a lot of muscle density. Some people, and you can see this, their musculature is variable. For instance, some people have thin, ropey muscles. So for me, I don't really have very big, massive muscles. They're kind of more kind of thin and ropey, which pretty much means if I'm going into that overweight range on my BMI, it's probably due to fat. However, there's other people whose muscles are just very massive. They just have a very, very big, massive muscle. That's just the way their genetics is. Their muscles are massive relative to what other people their same height and body frame are. And that is going to artificially inflate your BMI. And so you always have to be careful with BMI. And not only that, but you also have to be careful when you go to the doctor's office because your BMI assumes that it's your naked weight. But when you go into a doctor's office, like in the dead of winter, you've got your boots on, you've got your coat on. I mean, you've got all this extra poundage, not to mention all of the water that you drank, which actually adds considerable number of pounds to your weight itself. Water can add several pounds of extra weight to your body. So always be aware of that. That's why weight is something to be monitored, not something to freak out about. Okay, let's take a look at our nutrients, right? So basically, we'll have different types of nutrients, but most of them we need because they have some sort of physiological function in our body. Typically, they'll either be providing energy, they'll be providing for our growth, our development, or they'll be necessary for cellular metabolism. For instance, we're going to be needing to eat carbohydrates, we need our lipids, we need to eat our proteins, we need to eat minerals and vitamins, right? So we need to eat all of those. So carbohydrates basically are either simple or complex, right? So basically glucose, for instance, is our simple sugar. And we talked about this in the macromolecules chapter, so I don't want to belabor this point. But basically what we'll do is we we can use fatty acids, but your brain primarily uses glucose. So you eat a lot of glucose and use a lot of glucose for your brain. That's the reason why you want to make sure you eat well before an exam when you have to concentrate on something. And so grains, breads, cakes, cookies, things like that will oftentimes have lots of glucose in them. And then fiber typically is something that's good because fiber, remember, will help you to kind of clean out your colon. And so the fiber piece is really good. But however, when you refine these grains, like refined flour, what you do is they remove the fiber and they remove the vitamins and the minerals, right? Which is the reason why these processed flours are not really nutritious. Whole flour with the fiber in it, with the nutrients in it, is what you really want to go for. So when you take a look at complex carbohydrates, that means there's a lot of different types of carbohydrates in there. You can get them from different sources, for instance, beans, peas, nuts, fruits, things like that. Whole grain products, not refined grains. So these are going to have a lot of vitamins and minerals in it, right? So the idea here basically is that these are the nutrients that we're going to be needing. Now, in soluble fiber, as opposed to soluble fiber, is going to be what adds to our bulk into our feces, right? This is the indigestible stuff that we just mentioned that basically moves through the large intestines and gets eliminated through the colon. Soluble fiber, on the other hand, is a little bit different, right? So this and it kind of prevents the molecules, especially your cholesterol, from being absorbed. So it prevents absorption of cholesterol. By binding to it. So it can't get in there and then it just gets passed out of your system. This is the reason why oftentimes always you want to eat fiber, lots of fiber, soluble fiber and insoluble fiber, right? They're good for you. That's the reason why if you eat cereal, you want to eat a high fiber cereal, right? With a combination of both insoluble and soluble fiber. So can they be bad? Of course. Typically, if we refine our carbohydrates, like fructose sweeteners, things like that, they can basically add to our obesity. And so they have what's called a high glycemic index. And what a glycemic index is basically a measure of molecules that have the ability to quickly impact your blood glucose levels. Right. The reason why we like complex carbohydrates is because complex carbohydrates take time to break down. It's kind of like eating a time release capsule. Like some of you may have, they used to do this before the days of Gatorade and things like that. But back in the days when you were on a team, a coach would tell you to carbo load, right? So they would tell you before the big game, the night before the big game, go eat a big pasta dinner, go eat a bunch of spaghetti or something like that, starchy foods, complex carbohydrates. And the idea was you were carbo loading. That means you're filling your body with complex carbohydrates so that the following day when you're in the game, as you were spending these carbohydrates in fuel during the game, you could slowly break down those complex carbohydrates you ate the night before as kind of a constant, steady fuel source. So those complex carbohydrates are not hitting your blood glucose right away. It's kind of a slow release. But something with a high glycemic index is basically going straight to your blood glucose levels and increasing your blood glucose levels quickly. And so they rise very, very rapidly. And so as they rise rapidly, your pancreas has got to respond. It basically produces a bunch of insulin in order to bring those levels down. It puts a lot of stress on your pancreas. This is one of the reasons why if you eat a lot of sugars and you eat a lot of carbohydrates throughout your life, it tends to form type 2 diabetes. Why? Because you're exhausting your pancreas. Your pancreas is constantly having to bring these abnormally spiking blood glucose levels down to normal when it shouldn't have to. And so when you have these chronically high insulin levels, basically this kind of starts is what leads to that type 2 diabetes. You wear your pancreas out, basically. So how do you reduce your high glycemic index? First of all, eat less sugar, right? So candy, soft drinks, ice cream, pastries, all the things we love. Don't eat as much, right? Eat fruit, right? So it can be fresh, frozen, canned, as long as it's not syrupy, right? Eat less sugar, pure sugar, like white, brown, or raw sugar. And so anything else, a lot of people like honey, but honey has a lot of sugar in it. That'll go right to your blood glucose, and also syrups, right? Sweetened breakfast cereals, go for high fiber, less sugar. Jellies, jams, preserves, those kind of go in the syrup situation. Instead of cooking with sugar, cook with spices, right? So don't put sugar in your tea or coffee unless you have to. Like I drink my coffee black. And try to stay away from processed foods as much as possible because oftentimes they have refined everything in them, right? So refined carbohydrates, refined everything, refined sugars. So proteins is another one that we have. So we have essentially 20 different amino acids. There's 8 of them that are essential. That basically means that we can only get them through our diet. We can't make them. And so we have what's called complete proteins in our diet, which is essentially contains all of our essential amino acids, all 8. Usually this comes from animal sources, so the vegans have to be careful with this. So if you have a non-animal source, for instance, the proteins, tofu, soy milk, and things like that, we can manufacture those or we can process those, and we can add the completion to that. Incomplete proteins basically are from plant sources. So again, this will affect the vegans. And you typically need to add other types of protein sources in order to get all of your essential amino acids. For instance, you have to ingest these amino acids and you have to store them. So like, for instance, it's not uncommon for a vegan to have to supplement their diet with different types of proteins just to make sure they're getting their complete protein complement. Okay, can proteins be bad? Obviously, anything in abundance, overabundance can be bad, right? So if you take in too much protein, you can get dehydrated during exercise. It can also lead to calcium loss, which is a bad thing. That'll also weaken your bones. And it can also cause kidney stones as well. And so this is basically the formation or the coagulation of minerals in your kidneys where they start creating stones. If you eat too much red meat, which is a lot of protein, you can create a lot of cardiovascular disease because it has a lot of fat in red meat. Okay, now let's take a look at those fats, right? So the fats we have are fats, oils, and cholesterol. So basically you have saturated fats, which are typically animal origin. Usually they're going to be solid at room temperature. Things, for instance, like shortening and lard are good examples of these, right? So basically butter, real butter, not, coconut oil, which is saturated. So that's actually an unusual one because usually they're animal, but these are 2, palm oil and coconut oil, that are very, very saturated. So they're not really great types of oils to use. Meat fat, so pretty much fat in all meats. Then we have the unsaturated. So the unsaturated, basically, they don't have as much promotion of heart disease because they're typically healthier. They're a healthier type of fat. So typically they'll be from plant sources, so corn oil, safflower, grapeseed oil, things like that. And so these oftentimes will have what's called polyunsaturated fats. So these fats are basically not as bad as the saturated fats because your body metabolizes them. Basically, there's fewer fatty acids in a polyunsaturated fat, so your body's not actually consuming as many fatty acids. So there's actually some oils, however, and some fatty acids that are really, really positive for cardiovascular system. So some are very positive. For instance, linoleic acid and linolenic acid are 2 fatty acids that really have good beneficial cardiovascular benefits. So olive oil, canola oil, these tend to have more monosaturated, so they're healthier than most other fats. The omega-3 fatty acids, right? So these guys are important because they're actually protective against heart disease, which is the reason why you want to take your flaxseed oil or your cold water fish, like fish oil, because these omega-3s are actually very pro-cardiovascular they also are important in brain function. So you want to make sure you take these omega-3s. That's kind of what it looks like. So here we have a graph of the percent of saturated fat, which is typically the one that is the least healthy for us. You have monounsaturated fat, which is better. And then you have polyunsaturated fat, which is really good. And that's really what you want. So for instance, if you were going to cook, here you can see canola oil is going to be 62% monounsaturated, 32% poly, and 6% saturated. Safflower oil, however, has almost 80% polyunsaturated fat. So this is the one to use. That's going to be the healthiest of these oils. Okay. You can see in olive oil, you've got a lot of monounsaturated, not bad, right? It's about 1-to-1 in beef fat relative to saturated. So you can see there's a lot of saturated fats in there. Those are the bad ones. In butter, a lot of saturated. In coconut oil, it's even worse than beef fat, believe it or not, coconut oil. So it's a very, very fatty type of a lipid. So these polyunsaturated fats are the ones that basically are the healthiest for us. Can lipids be harmful? Of course, the answer to that is yes, because they are a risk for cardiovascular disease, and especially if they're increased in our diet, especially if they're in the form of the saturated fats and cholesterol, right? Because if you have a lot of saturated fats, basically that's going to add to hardening of the arteries, which is atherosclerotic plaquing, which will limit blood flow. Basically, what will happen is the plaques will essentially start to build up in your bloodstream, which will start to occlude blood flow. Cholesterol typically is going to be carried by two different transport proteins. One that's called a high density lipoprotein, HDL. This is the good cholesterol. When you do like a lipid panel at the doctor's office, this is the one they measure as good cholesterol. And then low density lipoprotein, right? This is the bad cholesterol. So basically the HDL, the good cholesterol, is the one that ends up in the liver where the cholesterol is metabolized, and it basically helps to reduce plaquing. The bad cholesterol typically is deposited in the tissues, and this is the one that gets lodged in the arteries. Now, as a result, what happens is you can actually, you increase your LDL load by eating lots of saturated fats, which basically increases your ability or your risk for cardiovascular disease. You can increase your HDL by exercising, which is the reason why exercise is good. Okay, we're not done yet. Trans fats. So trans fats are really, really bad, really bad. Basically, a trans fat is a situation, then we manufacture these when we take a saturated fat and we hydrogenate them to produce a solid fat. Generally speaking, these are all in packaged goods, like the things we love, cookies, crackers, things like that. So whenever you see in the list of ingredients, if you see partially hydrogenated, whatever, doesn't matter, some sort of an oil, that is trans fat. So this is basically artificial. So we create this. As a preservative. And as a result, our body doesn't know what to do with it. And as a result, it tends to stick in our body. And what it does is, if you were to take a look, say, for instance, at saturated versus unsaturated, right? Saturated fats, if you take a look at LDL and HDL, saturated fats will increase your LDL, right? Unsaturated fats will increase your LDL less. So exercise will increase your HDL, but trans fats, here's what this does. It increases your LDL by a lot, but then it decreases your HDL. So it actually kicks the chair out from underneath you. So your HDL doesn't have the ability to be good because it kicks that. So it's like a double whammy, right? So how to reduce lipids in your diet? First of all, lean meats, poultry, fish, things like that. Take the skin off of poultry because it retains a lot of fat in it, right? Trim your fat. Either broil or boil or bake rather than fry. Try not to use oil frying. Try to eliminate butter or creams or trans fats, or if you do, try to get the light versions. There we go. PowerPoint number 2. Okay. So try to eliminate these altogether, or if you do, get the light versions. So trans fats shouldn't be there at all. So try not to use shortenings, things like that. Again, use spices, right? Not lipids, and try to get lean milk, right? So also, cheese is very fatty. Egg yolks have fat in it, but eggs are also good because they got lots of protein in them. So eggs are not to be shied away from. We did a huge disservice to eggs, and eggs don't have nearly as much cholesterol in them as we thought they did. So we completely assassinated egg for no good reason. Don't eat liver, things like that. Shellfish is really high in cholesterol. It'll stick to you for a long time, and so forth. So basically, those are some tips and ideas. So minerals basically are kind of the inorganic things that we need. What does that mean? It's not inorganic like organic gardening. It's inorganic meaning containing carbon, right? So basically, these are non-carbon containing. Usually metal ions. A vitamin typically is a carbon containing molecule. So generally speaking, we have certain minerals that we need normally about 100 milligrams per day. A trace is less than 100 milligrams per day. These are helpful in our enzymatic reactions. So for instance, iron is present in hemoglobin, so we need iron. Iodine is part of the thyroid hormone, so we need iodine. Zinc and copper and manganese are present in enzymes, so we need these iron and metal ions to help us out. So here's kind of a table of our different minerals that we have that we need to consume in order to facilitate our physiology. So I don't want to go through all of them, but suffice it to say, just if we eat a good nutritious meal, we should be getting minerals, vitamins, and nutrients. So what if we don't have enough, right? So sometimes we'll run low on iron, calcium, magnesium, zinc, and other things. And so that's the reason why you want to kind of supplement your minerals with a good general supplement. Females oftentimes will need more iron than males because they're losing hemoglobin, which is what the iron is for during menstruation. And so they oftentimes will be iron deficient. And so this will kind of complete your diet. So calcium is important in your bones and teeth. It's also important for bone density. So if you don't have calcium, then you're going to become osteoporotic, which basically is a loss of bone density, which becomes a very big problem. It also is going to be co-absorbed with vitamin D. And so that'll help you to prevent bone loss and strong teeth. Sodium does a lot of things, right? So this is our major strategy to regulate water balance, keeps our blood pressure going, moves things in and out of the cell. We recommend roughly about, a gram and a half. Normally we have more than enough, right? So about twice that for the average American. We love our salt. And so that can create hypertension, but oftentimes we'll just offload it in our urine. So to reduce dietary sodium, obviously, right, don't eat salty foods, and then of course use spices instead of salt itself. Okay. Now, vitamins are organic compounds, which are basically means they're carbon containing. So they're typically involved in metabolism of various types. We don't have a lot of them, but they typically are coenzymes. That means they assist enzymes in our chemical reactions. So, so generally speaking, the fat-soluble ones will oftentimes absorb in our large intestines, and the water-soluble ones will absorb in other places. So here's kind of a list of our vitamins. I don't want to go through this list. This is just a table for the different vitamins that we have here that we need to get our B complex and so forth. And so antioxidants, basically, these will decrease the rate of oxidation. So basically kind of protecting us from harmful effects of oxygen byproducts, things like superoxides and hydroxides and free radicals, right? These basically will all damage tissue. And when you damage tissue, you can cause mutations and you can cause all sorts of bad things. And so the antioxidants basically will sort of detoxify. So these detoxify oxidizing agents. And so we have this a lot, right? So some vitamins are very antioxidizing. So C, E, and A. It's the reason why we like to take those. So we'll see a lot of these in fruit and things of that nature. Vitamin D is kind of an important one to kind of mention separately because this one we need in order to create calcitriol, which basically allows us to absorb and promotes the absorption of calcium in our intestines. So D is what's called a coabsorbent, right? So this is basically, or calcitriol rather, is a coabsorbent for calcium. So you can't get calcium into your system unless you make calcitriol, and vitamin D basically is the beginning of calcitriol. So in the skin, basically you make the first precursor. This is a multi-step process after exposure to UV. Then what happens, it goes to the liver, and then it goes to the kidneys where it's modified into calcitriol. And the calcitriol will allow you to absorb calcium and keep your calcium levels up. If you don't have vitamin D, then you get what's called rickets, which is a calcium deficiency and abnormal bone development and growth. So you get bone deformations, bowing of the legs, for instance, defective mineralization of the skeleton, so weaker bones, basically. So deformed and weaker bones. Oftentimes we'll have vitamin D in our milk. So we add vitamin D in our milk in order to prevent rickets, especially in children where their bones are developing. And then, of course, all of this goes and ties into our basal metabolism, which is essentially the metabolic rate at which our body is burning. It's kind of like our motor, right? Our metabolic motor. At what level, at what basal metabolic rate is our metabolic motor burning? And so, however, whatever that rate is will require whatever calories in order to support that. So basically it's like how fast is your metabolism burning, then you're going to need a certain number of calories in order to support that basal metabolic rate. And so oftentimes if a person is not taking more calories than they need, they typically will not become overweight. They can't. Because being overweight is you taking excess calories that you don't need because you've already satisfied your basic metabolic rate, and now you have extra calories, and it packs those calories into fat for later storage. So if you're constantly running your calories at or below your normal basal metabolic rate, then you're not gonna have any calories left over to add to your weight. And so that's kind of what kind of the weight loss thing is. So ultimately, if you take a look at limiting the number of calories, that's oftentimes what we need to do in order to lose weight. Without exercise, typically your average woman, your daily calories is about 2,000. That's pretty standard. For a man, it's about 2,500. And so we take a look at the My Plate graph. Usually you split up your diet into the main groups, right? So you have some dairy, you have a little bit of grains, fruits, some vegetables, some proteins. Notice the name of the game here is balance, right? That's the reason why we get out of whack, is because we eat too much of one thing and then we get in trouble. When your diet is supposed to be balanced, it's okay to have sugar, it's okay to have fats, but you can't have only sugar and only fats, right? It's okay to eat the occasional Oreo, and Lord knows I love my Oreos. It's just that you can't eat the entire package, right? So basically, good physiology and good nutrition means that we have to have a balanced diet, moderation, not eating like binging, right? So that's our biggest problem, and that's the reason why diet plans typically are focused on balance, right? So basically, a good diet, you want to have food from all different groups because they supply different things, right? So your meat, vegetables, grains, and things like that. So dark green leafies are good. Orange vegetables are good because they have a lot of carotenoids in it. So that basically is antioxidant. Beans are good for protein. Potatoes and corn, limit those. Those are starch, right? Those are starchy. You want to go whole grains rather than processed grains, and use fruits and toppings and sugar sparingly. If you eat things that are high in omega-3, for instance, if you eat fish, such as salmon or trout or herring, and eat moderate. Notice the term comes up again: moderation, right? Moderate portions. And so you want to try to go for oils that have a lot of either monosaturated or polyunsaturated fats. So if you're shopping, look at the lipids and look for mono and polyunsaturated fats. Those typically will be healthier than if they're just saturated fats. Try to stay away from or eliminate trans fats or anything with a bunch of excess of sugars, cholesterol, salt, or any alcohols in them. And not only that, but this is a big one. Be physically active every day, right? Because your body wants this. So that is to say, burn those calories. Right? Don't let them get stored. Use them. You've got them. Use them. Right? So, of course, then we're going to round this out with eating disorders. We have a couple of different ones. Oftentimes, eating disorders are a complex construct of both social, cultural, emotional, and biological roots. So anorexia, for instance, is a psychological disorder. It's a fear of getting fat, usually kind of manifests in a self-induced kind of a starvation strategy. So basically high physical activity. It may or may not include purging, but basically it's a self-starvation. Bulimia is essentially a situation where you eat large amounts of high calorie food. That's the binge eating piece of it. But then what happens is you follow that hard after that by a purging episode. The idea is you basically eat too much and then you just avoid it. You just void it out of your body. You just purge it out of your body. So by going vomiting it all out. That's basically where bulimia comes in. Now, binge eating is essentially kind of like bulimia, only without the purging, right? So this is the overeating piece without purging. Oftentimes it's stress. Many folks are stress eaters, anxiety eaters, they're anger eaters. When they get upset or depressed or stressed, they reach for comfort food, right? They reach for something. It's usually something that's probably not the best nutritional choice. Like we reach for the ice cream when we feel sad or stressed, or we eat the cookies or something of that nature. And so this is a very common attribute that we see in terms of this kind of binge eating idea, that we don't just eat to satisfy our hunger. It's like we eat excessively beyond the number of calories that we need for our basic physiological needs. Muscle dysmorphia basically is a situation where a person thinks their body is underdeveloped, right? This oftentimes you see this in bodybuilders, where they have a preoccupation with the size of their body. They think their body is underdeveloped all the time. And so what'll happen is they'll just be obsessed about their diet and their body form. They'll do all sorts of wacky, crazy things with their diet, which is oftentimes not very good for their body. And they'll constantly be building and building and building their body. They're constantly in the gym. They're constantly trying to build that body. And in this case, it tends to hit more men than women. Okay. So that is the end, finally, of chapter 9.